So I think currently, obviously, there are several unmet needs when it comes to the treatment of non-motor symptoms. And I think two are especially relevant. One is that people need to be aware of the fact that non-motor symptoms exist in Parkinson's. We do tend to see, especially in the last couple of years, that people are getting more aware of the fact that there are non-motor symptoms, but still we see when people refer to us, but also among patients, not everyone is aware that Parkinson's is not just a motor disorder. There are also many, many non-motor symptoms. So it all starts with being aware of it, and just to highlight that, in non-motor symptoms in general, the rate of non-reporting into medical professionals can be as high as 50% for some symptoms, for some problems. So it's clearly we need to increase awareness. And then the other problem is the lack of comprehensive trials, of comprehensive research going on in looking into non-motor symptoms in Parkinson's. We've come a long way, luckily, in the last couple of years in terms of things like levodopa infusion, so intrajejunal infusion of levodopa and apomorphine do tend to have quite a good effect on a whole range of non-motor symptoms. And there are some trials going on in cognition and pain, but many of the other non-motor symptoms, such as sleep or urinary problems or sexual dysfunction, are lagging behind. And for some of these, actually no evidence is in existence. So I would say these are the two key unmet needs when it comes to non-motor symptoms in Parkinson's. Yes, so clearly non-motor symptoms are very important in Parkinson's disease. We've already briefly mentioned that it's not just about the motor symptoms, so not just about bradykinesia or rigidity or tremor, but actually non-motor symptoms are a crucial part of Parkinson's disease. And we know from many studies by now that actually if you look at quality of life, so what is important to someone who has Parkinson's, often we see that these non-motor symptoms are more important than the motor symptoms. So if you look at what affects quality of life, the non-motor symptoms appear to have a much bigger role in that than the motor symptoms. And then obviously it differs between people what is important to them, but especially in general things like sleeping disorders or constipation or urinary problems are very often mentioned by patients as being very disruptive, and also having to go to the toilet at night, which we call nocturia, is one of the most bothersome things there is, and many of these people actually will tell you if you ask them that most of these things or other sleeping problems are more important than all of their motor symptoms together. So clearly when it comes to quality of life, it's a crucial part, an essential part of the disease, which we need to be aware of, which we touched upon in the previous question already. So obviously when we talk in general about treating non-motor symptoms, there are different strategies you can adopt, and if you look at how non-motor symptoms manifest itself in Parkinson's, we see some of them are unrelated to motor symptoms, but some of them are clearly related to motor symptoms. So to give you a brief example of that, if we see a patient goes into an off state, so when he becomes very rigid, very bradykinetic, very slow, because of wearing off of the medication, we also see that certain non-motor symptoms, specifically or mainly pain, is a good example, will tend to be worse. So clearly if you can address those off periods, or if you can address the motor side of things, you will see the non-motor side improve as well, mainly pain, which has been shown in several studies, that especially that's one of the symptoms you can improve with dopaminergic medication. And then obviously there are also symptoms that do not respond to dopamine, so they're sort of independent of the motor state. But despite that, especially treatments such as apomorphine infusion or intrajejunal levodopa infusion are two therapies we use in advanced PD, so these are not for everyone, but we know if you give them, then not only the motor symptoms improve. So reasons for giving them would be wearing off or dyskinesia, motor fluctuations. But if you put people on these therapies, we also see that many of the non-motor symptoms improve. A few examples of that might be urinary problems that improve on apomorphine. There's also some evidence to suggest that it may improve cognition, so memory issues. And actually there's a whole range of non-motor symptoms that improves. And then one of the other sort of more specific non-motor symptoms you can target with treatments for which we have treatments is cognition. So things like rivastigmine, acetylcholinesterase inhibitors, sorry for that, are among the therapies you can try for cognition, and there's also some evidence by now. Luckily, we can treat sleeping disorders, with, for example, with melatonin or clonazepam for REM sleep behavior disorder. So there are things we can treat, but unfortunately, for some of the non-motor symptoms, there's no treatment available, not even with the intrageminal levodopa or apomorphine I briefly mentioned.